Good evening. It is Thursday, May 6th, 7:02 p.m. on the East Coast. I'm post-cold, so I have that cold voice, which really is good for radio. But anyway, hope everyone is doing well. Welcome to a very special town hall this evening. As always, before we start, we like to give everyone an opportunity to come in, say hello, let us know where you're from. So please don't hesitate to give a shout out. Let us know where you're from. Say hello. It'll be a couple minutes, and then we'll jump right into everything. So, and I always have to figure out how to get the sign off my forehead. So, sync or something. It's also the time where I pretend to be extremely busy doing something important, like, oh, right with you guys. I'm just, doing something important right now.
You have a great
Thank you, Joy. I appreciate that. So if you're just joining us, welcome to this week's town hall. We have a phenomenal group of individuals along with a great topic, very necessary topic. With that, please don't hesitate to say hello. Tell us your name, where you're viewing from. We'll get started in just about 45 seconds. So who's out there? Y'all are being very quiet tonight, so I expect lots of people. There we go. Hi, Jen, Baltimore, Maryland. Welcome. There's Mary from Chicago. Hi, Mary. Lena. Hello, Lena. It's good to see you. And Paola in California. There's Michelle in Latham, New York. I love seeing these new names. From Miami. I lived in Coral Springs for a while, Lena. It's 45 minutes northwest of Miami. We will get started in just about 10 seconds. Please continue saying hello and letting us know where you're from. And with that, there's Samantha from Western Maryland. Hi, Samantha. I really like seeing all these new names. This is fantastic. There's Miriam in Lake Worth, Florida. We have a Florida contingency. All right, so with that, why don't we get started? So welcome. This is our town hall, our Perinatal OCD town hall, Maternal Mental Health. It is also Maternal Mental Health Awareness Week, Mental Health Month. It's a big week and a big month, as frankly, for those of us in advocacy and that have built our careers around mental health, it is a daily endeavor, but we always appreciate the acknowledgement from the community at large. So Natalie from Tokyo, well, welcome from Tokyo. That's awesome. And I see a Canadian flag from Brianna, so thank you, Brianna. I hope it's Canadian, otherwise I just embarrassed myself. But anyway, it'd be so weird if it was some Eastern European country. Anyway, not that there's anything wrong with Eastern European countries. All right, I'm gonna stop tangenting. So my name is Ethan Smith. I'm a national advocate for the International OCD Foundation, which simply means I have OCD and I won't stop talking about it. Let me just go over some quick housekeeping and then we'll dive right into the conversation. Hi, Pam in Montana. Welcome. So this town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. International OCD Foundation is not a crisis hotline and should not be used if you're in distress or feeling unsafe. If you are in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline right down below at 800-273-8255. As always, we want to create as safe a space as possible and be kind and respectful. I always like to remind people that we are broadcasting live on various social media platforms. And so again, while we like to create a safe space, this is public and will be recorded and live on in the web sphere for generations, hopefully. So with that in mind, we're here to support you. You're here to support us. So please keep that in mind as you ask questions. We have no problem with you asking very personal questions, but keep in mind that it is public and be respectful of everyone. With that, I'd like to dive in to our guests for this evening. I'm really excited because this is a topic that I am not extremely well versed on. So I'm excited to learn a lot, and I think we have an amazing group of individuals joining us. So first, I'd like to introduce Joy Burkhard. Joy, just below me. Joy is the founder and executive director of 2020 Mom, which is a nonprofit social change organization aggressively working to close gaps in maternal mental health through education, awareness, and advocacy. 2020 Mom's projects include the brand's Mom Congress and the BlueDotProject, Mom Congress is a coalition of nonprofit organizations and individual members working to improve birth and support of early motherhood. And the Blue Dot Project is a national awareness movement for maternal mental health, which hosts the US's Maternal Mental Health Awareness Week social media campaign, which is pretty awesome. Joy also worked for the insurer Cigna, where she has spent nearly 25 years. She serves as a regulatory affairs leader and has a passion for quality improvement and innovation. She's a member of the American College of Obstetrics and Gynecology Expert Work Group on Maternal Mental Health and the California Maternal Quality Care Collaborative. I should have read these beforehand. There's a lot of alliteration going on. The nation's first agency working to solve the U.S.'s maternity mortality crisis. She's been recognized for her leadership and vision with several awards, including receiving the American Public Health Association Maternal Child Health Leadership and Advocacy Award, California's American Mother of Achievement Award, the Emerging Leader Award in Women's Health from the Federal Health and Human Services Agency, Office of Women's Health and Cigna's Volunteer of the Year Award. And Joy lives with her husband and two elementary, junior, high school age children in Los Angeles, California. So thank you, Joy, for being here. Next we have Allison Livingston. She's a Korean American who grew up in Montana. She currently I have questions about that. She currently lives in San Diego with her husband and 2-year-old daughter. Allison has her bachelor's degree in international business and master's in early childhood education. She's traveled to several countries and was a teacher for 5 years and a preschool director. Since the pandemic, she's been staying at home with her daughter. So thank you, Allison, for being here. Appreciate you. Last but certainly not least, we have Dr. Cindy Gale. Cindy is a licensed psychologist and a nationally certified school psychologist. She earned a doctoral degree from the University of Florida, where she received training in cognitive behavioral therapy and psychological evaluation in diverse settings. Prior to opening her own practice, Cindy worked as an assistant professor for UF Health in the College of Medicine's Department of Psychiatry for several years. She worked extensively in both inpatient and outpatient treatment, pediatric and adult programs, focusing on the evaluation and treatment of OCD and related disorders, autism spectrum disorder, and perinatal postpartum mental health, among many others. Cindy was the director and coordinator of various programs related to psychological assessment, OCD, and autism spectrum disorder. She has treated and evaluated individuals all over the world and has specialty training in cognitive behavioral therapy, including exposure and response prevention, parent-child interaction therapy, and habit reversal training for tics, Tourette's, and trichotillomania. She also has significant experience teaching and supervising psychiatry residents, fellows, graduate students, and mental health training programs, and postdoctoral fellows in behavioral health treatment modalities. Cindy uses a developmental model when supervising future mental health practitioners. She is engaged in research focused on ASD, which is autism spectrum disorder, OCD, and related disorders. She's also presented her work and areas of interest at the local, national, and international level to disseminate information on empirically supported treatments. Dr. Gale, thank you so much for being here.
Thank you for letting me be here.
All right. So as always, we encourage everyone to ask questions. Please feel free to load them in the chat thread, and we will definitely get to them in the order that they're received along as we go. But first, I want to dive in with Joy. Let's talk a little bit about why are you passionate about this particular subject, maternal mental health? Where does your drive and passion come from?
Yeah, it's a great opening question. Often people wonder if I have experienced maternal OCD, and first I want to share that I have not experienced maternal OCD, but I live with 3 family members, my 2 children and my husband, who have OCD, and my son in particular has challenged with OCD. A real significant challenges when he hit puberty, and so I am very much a champion for early intervention and helping parents understand what's going on, and certainly helping those experiencing these disorders during pregnancy and the postpartum period. I myself had experienced prior depression. I was saved from having more difficulties during pregnancy and postpartum because I had all the support around me to help mitigate risk, even though I was higher risk during my 2 pregnancies in the postpartum period. I also want to share, though, that I've lost my little brother to suicide. He suffered from depression just about his whole life, and so really became a champion when many of my worlds collided, both having an opportunity to do advocacy work to support women and children, knowing that maternal mental health disorders like postpartum depression or maternal OCD largely go undiagnosed and untreated, and also having professional experience working in the health delivery system with a large Fortune 50 health delivery company of Cigna, or health insurer, as many think of Cigna and others, to be knowing that there's really some opportunities to close the gaps in the health delivery system to improve diagnosis. I'm really glad to be here.
Well, we're glad to have you, Joy, and excited to hear more about 2020 Mom and the Blue Dot Project as well. I'm going to turn to Dr. Gale for a minute. I have a couple questions for Dr. Gale. The first one is, can you, from a clinical perspective, define perinatal OCD?
Yeah, so perinatal OCD, it's interesting because the research historically would say about 2% of women are affected. We also have identified that dads can also be impacted by this. We don't have a lot of research or any that I could find in terms of our LGBT community looking at same-sex parented families. So, we have some limitations there. There's not a lot of research, but about a month ago, there was some research that came out from Nicole Fairbrother and colleagues out of the UK. And what they found was that over 15% of women in their sample met criteria for OCD using the DSM-5 criteria. This is a huge difference when we look at 2% to 15%. And what they did that was different was that they looked at diagnostic criteria that were more specific to OCD during the perinatal period, looking at concerns related to aggressive obsessions related to the infant. So asking about contamination obsessions related to the infant. So there's this hyper focus about having fear around whether I'm going to do something wrong. Perinatally, during pregnancy can be related to, am I going to eat something that's contaminated that's going to then harm the developing baby? Am I going to do something wrong? Am I going to take a bath and there's going to be an amniotic leak and the fluids is going to leak and I won't be able to catch it because I'm in the water, for example. And so doing checking, is a seatbelt too tight around my stomach? Is that going to cause me to smash my baby? So checking related to that might be those might be some compulsions that one might experience. Postpartum might be, am I going to, throw my baby? I'm going to stab my baby. Am I going to sexually abuse my baby? Am I going to look the other way at the grocery store and maybe somebody will molest my child and I didn't catch it and I caused harm? So those are some examples of how perinatal and postpartum OCD might manifest. These are distressing. These cause impairment in one's overall functioning. So those are some core features to look at when making a diagnostic determination. Also, OCD LA has a nice screening tool for perinatal postpartum OCD that can be used for clinicians who are learning about how to, assess for this, whether you're an OB/GYN or a mental health professional or whomever, or individuals themselves who might look to want to monitor these symptoms and see what's going on. Let me look at a test and see if that's in line with what I'm feeling.
Thank you so much. And if you're looking in the comment threads, Fran will continue to post links as we talk about things to resources and things like that. There's a link to the Float Center. She just mentioned OCD-LA, the perinatal postpartum OCD test. There's a link to that. I have additional questions, but I want to for you, Dr. Gale, but I want to get into to Allison's story a little bit. So, excuse me. So, Allison, thank you so much for being here. I just want to start by saying thank you for being willing to share your story a little bit, and I just like to hear what was your experience like, I guess, in the beginning stages of this for you.
Yeah, so currently I have a 2-year-old daughter, but prior to actually the birth, I was having mini panic attacks, and anxiety would build up. And then when I did have the baby, my hormones went crazy and I had extreme anxiety to try to protect her in any way I could. Specifically, I remember feeling like I can't take care of her. Like, this small human being is not going to survive around me. And so I kept fighting it and blaming it on new mom anxiety, to then realize, like, I need help. And I was able to find a really awesome therapist who actually wrongfully diagnosed me with postpartum depression, because I feel like everyone hears postpartum depression. Are you ready for this baby? You're going to have postpartum depression. And I thought I had postpartum depression, to then go to a doctor and a nurse and find out that they believed I had postpartum psychosis. And that was not the case. So I had a lot of visitors, unwanted visitors, and they were questioning me. I was interrogated by the PERT team, which is like psychosis. I had Child Protective Services come, had a lot of company, and to then be rightfully diagnosed with postpartum OCD. And I am now able to put a name on it. I'm now able to mentally tell myself, I'm not going to hurt my child. My child is okay. Everything is going well. I had to do a lot of different things to try it out and figure out what was best for me. And it was, medication, support system, and just really labeling what I had, what my condition was.
Thank you, Allison. It's interesting. I resonate with your story. I too was diagnosed psychotic in an acute psychiatric facility as part of my story when it was OCD, which I had been diagnosed with 17 years earlier. And so it's interesting to me because it's a similar trajectory, but then there's a layer of a child on top of it, right? So it's like it's doubly stigmatizing. It's probably even more traumatizing just because you have another life and there's other things going on. And so, but I really resonated with that. I don't know that I talked to anybody else that had a similar experience as me. So thank you for sharing that. Go ahead, Joy.
I was going to say that this is why 2020 Mom and the International OCD Foundation, Allison's story is not unique. And it happens far too often that women are misdiagnosed or sent to the ER for intrusive thoughts, self-harm risk, when really women are suffering from intrusive thoughts and OCD and not actively suicidal or at risk for harming their children. And this is exactly why we formed the collaboration between 2020 Mom and IOCDF to look at 3 specific areas. And those areas are, what are the gaps in the research? Dr. Gale, I can't wait to get my hands on that research. I know the research committee and others are going to be very excited to see that study. What are the gaps in the research? What do we know? What do we not know about maternal OCD? What do we need to help providers understand? What are the screening tools? What are the training mechanisms to understand the nuances, the differences between, in particular, psychosis and maternal OCD? As Allison's story really illustrates, things can go horribly wrong when there's a misunderstanding, and this happens far too often. And I'm so glad, Allison, that as traumatic as your experience was, that your daughter is with you. You were not taken to the ER, perhaps held inappropriately for 40 hours or longer without a treatment plan. These kinds of things happen far too often, and we're so grateful for the partnership with IOCDF to get to look at these gaps. The other group that I didn't mention yet is public awareness, and what do we want patients and the public to understand, and how do we empower patients in this journey as well. So Allison, I'm just really grateful for your story, and know that there's far too many of you out there that have gone through far too much.
Thank you, Joy.
Dr. Gale, I was about to turn to you. I know you have thoughts, so go ahead, share.
I was going to say, I would argue that a lot of the families that I work with who have perinatal OCD are some of the safest people around babies. I mean, they are so committed to caring for their babies, and they are so concerned and wanting to make sure they do right for their family. And then to, go down this path, well, it's really scary where, I've seen people on the inpatient unit where I do my assessment and they need to go home. They need to be reunited with their families. We're going to get them treatment. They should not be on the unit, And so I think that it's really important for families and individuals to know that that we're on their side and we're going to help them. And I think a big part of this is proper education, proper training across multiple physicians, multiple providers, to make sure that people get, move along the right path and to increase our agility in providing effective treatment.
But I think you make a great point, right? Because we know that OCD attacks what we value most. And so, I mean, and the things that we love most, which is funny because I have self-harm that always makes me think that I love myself more than anything. But regardless, but I mean, that's true. And there you go. So I appreciate that. So I always say, I would trust, when I have a child, I would trust them more with somebody with POCD than anyone else, because we already know that, they can't. So you're absolutely making a good point. The other point is, this seems, and this can open up to anyone. This seems awfully logical in a way, because when you talk to the OCD population and you see the numbers, 1 to 3% of the population, we know that that's grossly underrepresented because, so many people are misdiagnosed. And it would only make sense that within that cohort is the mom, right, and the dad that are experiencing this, and that there's no way it could just be 2% of the population. So, all of this is such an aha moment. It's like, this makes total sense. And yet we're still here, and there's a doubly stigmatized issue here going on. So go ahead, Dr. Gale.
Well, and as the point that Nicole Fairbrother brought up in their paper as to why they think this has been documented is because how the screening tools have been used. The measurement tools that we have as clinicians don't speak to the infant, harm to the infant. They don't use those words precisely. So what they found was that when they were interviewing individuals, when they changed the language, people would say, oh, I don't have aggressive obsession. Oh, wait, yeah, I do have that thought. And I think that sometimes it's, when you are pregnant and when you have a baby, you're tired. I just had a baby, so I'm tired. And so it could be that they're just not thinking, about it in that way, but also could be a fear of what happens when I disclose this. What are the implications of me disclosing this? And when we ask the questions directly, then what we start to do is, if we have a common procedure in place, that we ask these questions, that people start to realize, oh, this is not an uncommon experience. Otherwise, they wouldn't be asking this so frequently. And I think once we start to open the dialogue up, have the proper screening measures, make them accessible, and have it be part of a routine practice, I think that will be a game changer.
Absolutely. Go ahead, Joy.
I was going to say, this is the challenge with all maternal mental health disorders too, is they all largely go undiagnosed and untreated, just like the general population. Mental health disorders, right? Primary care is not routinely screening in most settings, and there are quite a few barriers. We're really recognizing that obstetricians in particular, because new onset for these disorders happen almost as frequently in pregnancy as in the postpartum, can lead to preterm birth. All sorts of reasons why pregnancy makes the most sense to begin a screening routine. But recognizing that obstetricians, they're not reimbursed for these efforts right now, or at least they don't realize they can be. We have a brief coming out on all of this pretty soon, which will be helpful, I think, to the field. But there's just quite a bit, there's a lot of barriers. We talked about obstetricians really, and providers in general, just really needing some additional support in terms of education. They don't know what they don't know. Well-intentioned providers that care about their patients, or they wouldn't have gone into this field. But it's quite overwhelming for them. And so there's a lot of work to do to universally screen for all of these disorders, but including maternal OCD. And, there are thoughts about, do we screen first for anxiety? And then does that trigger an OCD screen? Or do we Do we start with just the Edinburgh screening tool, which is specific to the perinatal period? There's a couple questions about anxiety. Is that enough? How do we make this palatable for providers, particularly obstetricians, make sure they have the capacity to do it? And I really do think there's a lot to be said about patient education as well. And even just to list out the symptoms for all of these disorders on, Allison, we've talked about this in the past, not just a poster in an obstetrician's bathroom, which still helps, right? But in apps and like maybe, on Instagram, and where can you be very clear about the nuances of these symptoms so that a mom or her family can help frame, maybe it's this and not that. And, patients don't realize that providers aren't well educated yet. And it's really helpful, I think, for patients to be empowered to understand the nuances as well.
100%, yes.
I was thinking back to when I was pregnant and I was packing my bag, for the hospital, and we're in this pandemic, and there were talks about, maybe I was going to have my baby by myself and all this stuff. And I just remember, there were all these tutorials, and I ended up packing as if I were going on a 2-week vacation to like the Fiji Islands. I mean, it was just like so much stuff, and I didn't use half of it. And I just thought, well, how cool would it be if we started talking about, why don't you have these screeners, available to you? Like, have that after, I think even postpartum, there's a whole bunch of websites about and videos about what products you should buy postpartum. But what if we had these as part of a packet just to have in case anything comes up? How valuable would that be?
Yeah, or to have companies tape them to the diaper boxes or the strollers and the items that we purchase right online, Amazon.
Yeah, that would be awesome.
Yeah.
Dr. Gale, excuse me. Is there any research to show that there can also be a reduction in symptomatology during pregnancy itself? Because I know in other illnesses or mental illnesses or diseases or things like that, I had a friend with MS who, when she was pregnant, it completely went away just because of whatever chemicals and hormones were being produced. And I have a couple of friends with OCD that are recently pregnant, and their symptomatology completely disappeared. I'm curious what your experience has been with that.
Yeah, I'm not sure what the research says. I think clinically, I've had some clients who thought there was going to be an increase in symptoms and didn't have anything, and were kind of shocked, like, oh, I thought this was going to come up because, and I mentioned it, for prevention, from a prevention perspective, not to scare them, to empower them. And it's not anything. So I think, we also have to, that's the thing with OCD. There's over 1 trillion different types. They bounce around. You never know what type or flavor is going to come up. It's like whack-a-mole. You treat one, then it's like something else pops up. Hey, look over here. And, so yeah, I think, and that should be encouraging that if somebody has a history of OCD, not to be worried that it's going to happen to you, because it may not.
Absolutely. I also want to continue to encourage people to ask questions. We can actually turn some questions now, and I could ask questions for days, so don't worry. There won't be a lack of information coming out. Joy, did you have a thought?
I was just going to say, I think the research committee can list that topic that you just brought up, Ethan. Is there evidence, or should there be a study on actually documenting whether or not symptoms disappear, right? How do we capture these stories that you're sharing and see if there's something to it? I don't know that there is research yet. I think, to Dr. Gale's point, we haven't seen anything, but that's really interesting, and somebody should be studying that if there isn't research yet. So thank you for sharing that.
No, my pleasure. I want to get to some questions. Hopefully y'all are still on who asked them. Also want to ask Allison a question quickly. But I also don't want to trigger you. So I'm determining how to frame this. Now that's totally like, oh my God, what's going to ask me? You do not have to answer anything. But two questions. One is, because I think I already know the answer, but one is, do you feel like the experience of perinatal OCD and postpartum OCD really stole the experience of being pregnant and from you? And secondly, now that you have the knowledge and the toolkit and you're continuing to work on it, do you feel you actually have more ability to be present and experience the joy that can come of where you are with motherhood and things like that?
Yeah, so the first one, I think every new mom, every parent has expectations, and they have what they think is going to happen, and they have what they want to happen in their mind. It's like the birth plans. Everyone, either the doctor asks for you to actually write it out and you have it all settled down, or you go in and it's a C-section and whatever. Like, different people have different experiences. And I think looking back now, my postpartum OCD, perinatal OCD, it didn't make it horrible. It just gave it a twist onto something I didn't expect. And now, having all the tools and resources, I just feel empowered to spread the word and awareness. I don't know if I would want to go this route again in the future. But I currently am just really happy to share my experience. I think so many moms feel alone and isolated out there. And then a pandemic happened. And that's just a whole nother twist on it. So yeah, just fighting it and educating people the best I can at this point.
That's awesome. I just have to point out, I love watching Joy's face when you talk, Allison, or when Dr. Gale talks, because you're so passionate and you can see it welling up, and I can see in your face like, oh, we're gonna take care of that. We're gonna do that too. We're gonna I could be wrong, but I see it all over your body language is just like we're gonna attack all this stuff, and I think it's super. It's awesome to watch. I don't know. It makes me really passionate about it. So.
Yeah, we tend to like take on lots of things because of these stories. So Ethan, you're right about kind of reading into those things. Can I ask Allison a question too, Ethan?
Absolutely.
Allison, I think it'd be helpful for those watching, and I think I remember a little bit about your story, but can you remind us what kind of treatment? You said medication, and thank you for sharing that, because I think a lot of us recognize it can take the edge off, especially, and help us manage OCD or family members manage OCD. Did you also receive exposure response therapy or cognitive behavioral therapy? What did your treatment look like?
Yeah, so I was starting on an antidepressant, and I had information from IOCDF, thank you, that I would need a certain amount of medicine to actually really help me. So I asked for a higher dose, and the primary doctor was like, whoa, okay, and wanted to do a little research on that, but I'm still taking medication, antidepressant, and I did start exposure therapy, and I got a lot of mini homework pieces, I guess, to try to get through all those little anxieties that I had around the well-being of my daughter.
That's great. I would love, I don't know, Ethan and Dr. Gale, if you're thinking this too, I'd love to hear, would you be willing to share an example of something that you were asked to do and how it worked out for you?
Yes. So I had a checking compulsion where I would literally believe my daughter would flip over in her crib, or she wouldn't sleep properly. Like, she'd be turned, and I'm like, she's dead. SIDS, it's over. And so the therapist and I worked on, we have a monitor, a little camera, counting how many times I would check and slowly limiting it to chunks of time so that I'm not constantly watching the monitor every hour she sleeps, because with their newborns, they sleep a lot. But I was so anxious the whole time. I would stay awake. I was pretty much an insomniac for the first 6 months. Yeah. So I just worked on that. I worked on like the little times, and then I built it up. And my therapist showed me the bell curve and how at the beginning you're really nervous to try it, and it could be like, 15 seconds, and then you're at the top of it and you're like, I need to check on the camera. And then you finally come down and you feel a lot better. And then you're like, I did it. I can do it again. And you build that time. And that's exactly what I did to work on it.
That's so helpful. Thank you for sharing that.
Yeah, of course.
You had a great therapist.
I know. Yes. Yes.
We often
You're really brave, by the way. I mean,
thank you.
When you're mommy and you're having to confront these fears on top of it, and the people who go through treatment, when you're doing it individually, but then versus like doing it and you have a child involved or your family involved, I see the motivation go to another level oftentimes.
Oh yeah, you see the moms lifting the trucks, the adrenaline, just you sacrifice everything for your child. Yeah.
And that's what's important to point out too, is regardless of the onset, or right, what is the catalyst for OCD to come to the forefront, regardless of whether you're predisposed, still the treatment is, at least from a therapeutic modality, exposure and response prevention, gold standard baseline treatment, and medication. We know that the combination of both can be really, really helpful. And so, even though we're talking about something specific here with perinatal postpartum, it's whether you want to call it a symptom or a subtype or just a cohort of individuals, regardless of what the catalyst is, the treatment is exactly the same, right? Maybe how you have to cater or tailor it is different, but the treatment is the treatment. And that's the beautiful thing about the treatment that we have for OCD is OCD can be so debilitating as it is. And, as I love what Joy said about Allison's story, which is like, it's not uncommon. I think we all feel like at some point our stories are completely unique and original when they're not. They're not uncommon at all. What's uncommon, unfortunately, is Allison's current state of well-being and mine, which is like the wellness, right? That's uncommon, and that shouldn't be. We should not be the exception. We should be the norm. Like everyone should have access to effective, affordable care and treatment and getting better. And I know that's what Joy works tirelessly for, not just with OCD, but all mental health. But I think it's just important to point out, right, that that the treatment is the same. I want to jump into some questions here. And as always, if you're watching, please don't hesitate to ask questions. It can be about what we're talking about. We've also got some experts on a wide variety of subjects here, so if feel free to ask anything. But I'm going to first turn to Ashley's question at 7:16 p.m. She wrote, "I'm a checker, but when in my early postpartum with my first baby, I started having intrusive thoughts. This pregnancy, my intrusive thoughts have to do with having fear, worried that my anxiety, OCD, and sleep will cause preterm labor. Is this normal to go from checking and not having intrusive thoughts to then starting to have intrusive thoughts during pregnancy and postpartum?" Great picture, a great family, by the way, on the picture. So I'll ask Fran to take it down. Yeah, for hiding. I'll turn this to Dr. Gale initially.
OCD is just one of those things that it's a little pest, and it will try to get you in different ways. And, I wonder if, and I have a question for Ashley, and maybe you may not want to answer this or not, but I was curious if you were able to access help during your first pregnancy. I don't know if
we can. Well, I'll keep an eye down on at the bottom of the comment thread.
Yeah. So I think that and I also want to add another treatment modality. Exposure therapy is very powerful, along with mindfulness.
Acceptance commitment therapy, DBT, they're fantastic.
DBT, yes, and I think that when you have for this type of OCD, about the fear that your anxiety and the OCD and sleep is going to cause preterm labor, what makes this present moment feel intolerable is worrying about the future, worrying about the past. So how do we stay here? How do we not suffer as much? But I think that it can bounce around, and the key thing is to, if you've been able to participate in therapy, is to use those tools and treat it just like how you treated the other ones. And if you're having difficulty, reach out to somebody who can help you.
And was in treatment during her first pregnancy.
Oh, that's wonderful. That's so great to learn. Yeah. Yeah. And one thing is too, this is unpublished work that I had done, but we did some case studies of individuals in their second pregnancy. And it was interesting because I wasn't seeing them, come through our program, because the OB was seeing them. And what what they had found, and it was so fascinating to us, is that these individuals during the course of my work had not needed to return to therapy, that they knew what to do, that they felt like they were able to manage the symptoms. And so it was really powerful to see that, when you've had it one time, that oftentimes you can use those tools and techniques a second time to keep those symptoms at bay. And so that kind of goes back to Ethan, your original question that I didn't have a great answer for was, can they subside, can they fall off? And I think as there are more children, potentially, yes.
Thank you, Dr. Gale. Allison, did you, A, any thoughts, and B, did you notice your symptoms morphing and shifting, thoughts, fears, images?
Yes and no. Thank you, Ashley, for commenting. And I didn't actually think it was OCD. I was like, it's new mom anxiety, even though I'm not sleeping. It's new mom anxiety, even though I check on her the entire 12 hours, and I would just continue to say that as an excuse. But then I would have moments of just like overwhelmed, intrusive thoughts, like extreme anxiety. And then I would get through them and I would do it again, and it would build up. It'd be every couple months and then it would go away. So
thank you, Allison.
Like one moment.
Sure. Joy, any thoughts?
I love the conversation. What comes to me, and I think if there are moms listening who aren't sure if they have OCD, what could be helpful to share is that, checking and being worried about preterm birth, like those things can be normal, especially for first-time mothers, because second pregnancies can cause those same kinds of distress. But as Dr. Gale had mentioned earlier, and I think Allison, your story pointing out like 12 hours a day of just repeated checking and concern, when it becomes excessive and debilitating, that's when we're concerned that these fears and unwanted intrusive thoughts really can be a sign of OCD. So that's what comes to mind for me, for those who are watching and aren't sure if they've kind of crossed that cusp at this point.
That's such a great point, Joy, and I'll let everyone weigh in. But I think that there's two things here. I think one, Ashley, and thank you again for your question as well. I think OCD in general shifts and morphs at any period of time during your life. Change, major events, deaths, births, things like that. That is by no means abnormal. It's very, very, very common, regardless of the situation. I don't think this is any different, right? This is a major life event. There's new responsibilities. There's chemical and physiological changes and things like that. So it would make perfect sense that as Dr. Gale put it perfectly, it's whack-a-mole, right? You feel like you've conquered one obsession, one fear, and then something else pops up and you have to take a whack at that. I think Joy brought up a great point, which is, so often with OCD, we stigmatize ourselves so quickly to be like, oh, it's my OCD. It's my OCD. It's my anxiety. It's my OCD. Sometimes it's just life. Sometimes it's anybody in your situation would be doing or going through the exact same thing, right? So this brings up another great point, which is OCD thoughts are not unique to individuals with OCD. We all have the same thoughts, right? So for those of you with OCD that think your thoughts are completely different than people without OCD thoughts, that's not true. Everybody's got the same thoughts floating around. We just start to put a spotlight on it and they become cyclical, and then we attach emotion to it and it gets intense, right? But the thoughts are the same. And I think that's important. I think that's important that Joy brought up, right? Is that it's not always OCD. It's not always anxiety. Sometimes we're just going through that common humanity, that struggle that everyone else goes through.
That's great. Ethan, I have a question for Dr. Gale, if I may.
Yeah, absolutely. Yeah. I love this. I'm having you on all of these.
We're having fun, aren't we?
Let's see if I have an answer for you.
One of the things that we hear, and I think that mental health professionals struggle with, and with OCD in particular, is exposure response prevention, treatment, and therapy is what if a mother has a fear of harming her baby? How does the therapy look like? And what does that look like? And what comes to mind for me is there's examples and stories about mothers having fears harming their babies with a knife, right? A knife in the kitchen. So they go hide the knives, and no one can bring knives in. So in that case, could exposure response treatment look like bringing the knives in and sitting in the kitchen for 20 minutes, and then another 20 minutes, 40 minutes total, and kind of edging up to know, okay, look, I was fine. Just curious to get some more thoughts on that, because it has been quite a debate in our field, is how do you do this when it's about a fear harming the baby?
I see Allison nodding her head. I'm wondering if you had any experiences with this at all. You don't have to answer the question if you feel uncomfortable.
No, that's fine. I had also a compulsion around plastic bags. And I think it arose because on every plastic bag, it says, do not let children or babies play with this plastic bag. It will suffocate them and they will die. And so the crinkling of a plastic bag would make me cringe. And I would change the trash bags, and it was very hard. And so, yes, Joy, I would do mini exposures, and that helped me. And now I just can grab a trash bag, hear the crinkle, pop it in, and it's totally fine. And it was that build-up exposure therapy that really helped me get through that, as well as labeling. Like, am I going to put this bag over my child's head? No,
you're really brave, Allison.
I have OCD.
Yeah, and you can see how powerful that is. The experience of doing that with somebody a clinician who's trained, who trusts you to do this, and then you start to develop this trust in yourself that I'm not going to murder my baby if I'm around a plastic bag.
And I think, yes, that's so important to hear as
a mom. It is really important, and it's really important for individuals to feel like we're on their side. I've had an individual's fear that what if there's a switch that flips in my brain and all of a sudden I do something awful to my baby, because a lot of psychotic stories kind of are presented that way and how they're sensationalized in the media. To hear a therapist say, I'm an expert on OCD. If anything happened, I would defend you in court.
Yeah.
I'm on your team.
Yeah.
Well, it's
but to answer Joy's question, so I think there are different philosophies, and I think we also have to meet people where they are. If I have a client who says, I don't want to do that, we have to respect that and we have to honor it. And there are, thankfully with OCD treatment, we have two methods. We have exposure therapy and we have mindfulness-based approaches that can work. And so that's my philosophy, is one is meeting people where they are. People come in with their own stories. If you have had somebody who had been a part of the foster care system and moved around and was taken away from their parents, and they come in and they have OCD and their thoughts are triggering this, I'm going to harm my baby and my baby's going to be taken away from me. We have to process that. We have to honor that. We have to honor their stories that they come in with, their stories about how they were parented, their spiritual, their religious, their traditions when it comes to child rearing, what happens in the postpartum period. But I have done exposures like that with individuals, and it's been very effective from my experience. I've had people hire chefs and nannies to supervise them at all times because they were so afraid to be alone. They could not cook for their families. They could not be alone. They couldn't drive their children because they were going to get into a car accident and kill their family. And at the most extreme version of this is what a picture of what somebody might look like if they've accommodated their OCD. The trickiest part, I'll say this, is what happens when you have somebody who has been not diagnosed with perinatal OCD and their child is 3 years old, 5 years old. It is unethical to do harm. You have to think about that. And so that's a different story.
Yeah, absolutely. And I relate to so much. My own personal experiences, I relate to so much of this. I was to a point where I was in bed and unable to function, and I had my parents watching me 24/7 because I was self-harm and I was so afraid I was going to accidentally impulsively kill myself in a variety of different ways. And, to your point, Dr. Gale, there becomes and Joy, and Allison, everybody here, but right, it starts to feel like a gray ethical question when you have these more extreme cases, because like I would go to therapy and they would literally say to me, all right, well, go home and kill yourself. And I'd be like, and for them to say that, it sounds like immoral. Like, why would you ever say that? But like, they were so confident in the fact that it was OCD, that it was ego dystonic, as we say. It was so against my values, but it was terrifying. And like, as a clinician, it's really difficult to be able to treat that in a way that's effective, but at the same time safe. To piggyback on Joy's question, and Eric, I see your question, so I'm not I'll get back to it, I promise. Devorah asked a question at 7:42 p.m., which was, is there any limit to ERP when there is a baby involved, using a knife near a baby? I know we discussed the plastic bag a little bit, and you talked about meeting people where they were, but I thought I'd touch on Devorah's question and see if you had any other insight.
Yeah, and one of the things, this is like a separate point, but sometimes grandparents can develop OCD around their grandchildren. So I'm just thinking of a story where I had somebody, who had this fear that they were going to harm the baby. So we brought groceries, into the clinic, and we used knives, and we were doing exposures, where the baby was near the knife while they were cooking in a safe way, obviously, but, making sure that people are able to live independently, live a life according to their values. If you value cooking and you enjoy that, or you want to feed your family, let's allow you to be able to use your utensils. How do you manage those thoughts when they come to mind? Holding things near the baby, a screwdriver, sharp objects, scissors, things that you interact with on a day-to-day life that are in your household. It's important to be able to interact with them around the baby. So I have had experience doing that with the babies present. And it's so fascinating because you can see the look on the face of these moms or dads, and they're so terrified. And then it's a joke, and they're like, oh my goodness, this thought has no meaning, no power. I would never do this. And that's where proper assessment comes in. You do need to properly assess and make sure that these are ego dystonic, that they don't, that they care, they love their babies, they want to protect their family. But the weight off their shoulders and the look on their faces when they realize I am not a danger to my baby speaks volumes to what kind of, and two, it speaks volumes to what kind of parent they are, that they're willing to do this, to challenge, to overcome, so that they can live a life that's meaningful, is powerful.
For sure. Thank you, Dr. Gale. I appreciate it. I have a question for Joy, but I'm gonna say two things. I remember I had a memory just pop in where my cousin had given birth, and at 3 or 4 months old, and I obviously had OCD, but even so, we were in the mall, and we were back when we went to malls. We were in the mall, and we were on the 2nd or 3rd floor, and it was one of those open malls where you had it. And she handed me the baby while she was doing something. I immediately thought, what if I want to throw the baby over the balcony like a foot? And like, I could feel my arms start to tingle, and I was like, oh my God, do I want to do it? What? And so to Ashley's point about like new thoughts, like I'd never had that thought in a million years that I was going to like throw a baby over a balcony, but like instantly I was like, oh, you take it. The other thing, and this is in no way, I brought this up in a previous live stream. You're going to find it funny, but it relates, which is I'm a new cat dad. So I'm in no way comparing my experience to Allison's experience. But what I will say is I've had pets as a kid, right? But my parents took care of them. My girlfriend and I adopted 2 kittens about 7-8 months ago. And I started having all kinds of intrusive thoughts that I've never had in my life before. What if I want to turn on the stove when walking over it? What if I want to like be sitting in my lap and they're so fragile? It's like, what if I want to snap her spine? What if I want to do that? What if I want to break her neck? And I was like in visual thoughts about cutting off. Sorry to trigger everybody, but like, and it seems silly because they're cats, but like, I can only equate this to, then I was like, oh my God, I want kids. Like, what is that going to be like, So I bring that up because I think it's a valid comparison to a certain extent, right? I mean, like I'm in the charge of these cats, and I'm having all of these new, intrusive, intense, violent thoughts about what I may or may not do to these cats.
I think it's absolutely a valid comparison. And Dr. Gale, I'm curious, isn't it the part of the brain that produces the love hormone that lights up with OCD? Am I remembering that correctly? Like it is
The amygdala?
Is it the amygdala?
The amygdala is a fear reaction. We call it, yeah, and with people, I'd say it's an alarm. It says, uh-oh, to things.
Is it part of the brain that connects us to the things that we love? And what am I remembering about that? These fears are really...
I think it targets things that are really important to us, things that we value. And Ethan, you're a cat lover, and I'm a cat lover. and I think that, the fact that you care so much about your pet and the fact that OCD is targeting this, it just speaks volumes to what kind of cat parent you are, and the same is true for anybody who is questioning, whether they want to be a parent and kind of OCD symptoms might manifest or whatnot. It just speaks volumes to what kind of person you are.
Yeah,
absolutely.
And can we stay on this topic for just a moment? Because these are the scary thoughts that people think, am I experiencing, am I psychotic? What kind of person would think these thoughts, right? That's where we go. And then we think, okay, psychosis. I must have psychosis when it's not a break in reality, right? Because that causes you distress, these thoughts, right? And Dr. Gale, you can speak to this professionally, but I think it's helpful just for those watching, because there are so many misconceptions, to understand that this is why it's not psychosis, because that the thought is disturbing to you, right? It's not a break in reality. It's not a hallucination. Right? You understand the thought and it concerns you. It's not a hallucination or a delusion. Dr. Gale, can you speak to that or want to add?
Yeah. I remember, as one of the most famous postpartum psychosis stories was the story of Andrea Yates. I don't know if you all remember her. But she had killed her children, I think, by drowning them in a bathtub. And she had this belief, and I may be recalling incorrectly, but it was this delusion that she was going to save the world or something like that. And so it was she was sacrificing her children. If I'm doing an assessment, and this is kind of the nature of the conversation, it's ego-syntonic. I have these beliefs. I'm believing them as true. There's individuals are presenting out of touch with reality, might have, other symptoms that are present that are concerning, poor self-care, poor sleep, agitation, I don't want to oversimplify it because it is very important and it does come up. But that's where we start to think about, okay, let's get this person more intense services and supports. Medications are oftentimes a frontline treatments for those, types of conditions. So because talk therapy isn't going to be sufficient. So let's get those individuals, the care that they need. But if somebody coming in and says, I have this thought every time I go down the stairs, I'm going to throw my baby down the stairs. And then it's so silly. And I would never do that to my baby. But it makes me so scared that I just stay downstairs all day long. I have my partner go up, take the baby up and down the stairs, and there are things that I need up there and it's been a huge inconvenience or whatever, that now there's impairment, it's affecting their quality of life, they're limited, and let's start to treat those types of behaviors. So I think can be a key differentiation of is somebody in touch with reality or not?
Go ahead, Allison.
Yeah, and I just wanted to mention, I was asked if I was hearing things that other people were not seeing or hearing. And I think that was really important, because when you are pregnant, all your senses are heightened, right? Your smell, and just you feel like a superhero in a way. And so I would be like, is the fan moving? Am I hearing something? But it would be, the fan was moving and it would be fine. So I think that's also a good kind of check-in. Oh, this is real.
Thank you, Allison. Yeah. I'm gonna go ahead, Joy.
Oh, I was just acknowledging really helpful responses. Thank Thank you.
I'm gonna weigh in too. I'm by no means a doctor. I played one on TV in CSI Miami in 2003. Just plugging myself. It's fine. But I'm gonna throw out, and Dr. Gale, please agree or disagree, because I could definitely not stay in my lane. But for me, there's two differentiating factors, right? The first one is the presence of doubt, the presence of I'm not sure, right? Individuals with psychosis don't doubt their psychosis. They don't doubt that. If you have an individual with, and I learned this like being in a psychiatric hospital inappropriately, but individuals with schizophrenia didn't go, I think the government is tracking me. They were like, the government is after me. I know this 100%. They're listening, right?
Yeah, it's a fixed belief.
Exactly.
It's a fixed belief. Yeah. Mm-hmm.
Now, I do think there's ranges. We call it OVI, overvalued ideation. How much do we believe the OCD thought? How much do we, right? So there's different levels of how much I believe in the uncertainty. I could put so much weight in that 0.1% that something might happen, that it almost appears delusional or potentially psychotic, but it's still OCD, because deep down, I'm still not 100% sure. I'm like, I don't know for certain, but I might, or it could, or this may. So for me, the presence of doubt is a big differentiating factor in psychosis. The second thing is from an educational perspective, from individual with OCD, which is when you don't know a lot about OCD, when you're not educated in it. I remember being in the offices and being diagnosed, and because the way I verbalized things was not how I was actually thinking or feeling. So I would say, I'm going to kill myself. Like, I know it. I can feel it. I'm going to kill myself. My OCD says so. So the first question they ask is, oh, you're hearing voices? Because they don't understand. And second of all, they take me at face value. What I really meant was, I am so afraid I'm going to kill myself. It feels like I am. I don't want to. I have no desire to, but what if I do? And I kind of think I am, and I may, but I didn't. That's not how I presented it. How I presented it was like, oh no, I'm going to do this because like I'm scared and blah, 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 blah. And that's where the education is so key, the diagnosis and the education. So I know how to properly present what I'm experiencing, to a professional. And that's where I know I got myself into trouble. Like, they started like, well, he has schizophrenia, he's hearing voices. I'm like, I don't hear anything. We say our OCD told me that, but I don't hear that. So I think like from a patient perspective, go ahead, Dr. Gale.
No, I agree with what you're saying. You're training in CSI.
I just talked to a lot of experts.
I would agree with what you're saying, because, and I think there's also something clinically, when you're sitting down and talking with somebody, there's this energy, there's this vibe, there's this, what are the words that they're using? How is their affect? How is that aligning? Are they excited about what they're saying? Is it congruent? How is their self-care? What do people smell like? What do they look like? How, and so I think there are all these, there's the DSM criteria, but there's also all this other data that we're getting and that we're assessing for to make a proper diagnosis, because my number one job is to keep people safe. And I love babies. I'm not going to hurt a baby. I'm not, and so when I'm doing an assessment, and if we're going that harm route, and that's what needs to happen, and we need to do some harm exposures to help them overcome whatever they're struggling with, I need to be confident, that we're going down the right path and help them develop that confidence in themselves, because that's the most important thing, not what I think about them, but what they think about themselves.
Thank you, Dr. Gale. We have some great questions, but there's one hanging around from 7:22 p.m. that I want to get to. I'm going to direct this at Joy. So Eric Lamfran at 7:22 p.m. With the increased focus on mental health over the last few years, do you feel like these stigmas are decreasing and it's easier to talk about or find resources? What is the current state of affairs with where we are in this journey?
Yeah, and others jump in here, but I think it's certainly the awareness of mental health and talk, at various levels, more television and, mental health being discussed in movies, and great efforts behind the scenes to help entertainment cover mental health effectively. Government's really focused on mental health in a bigger way. At all levels. So I definitely think all of this is helping. And younger generations, I think, are much more comfortable talking about mental health and getting access to care as soon as possible if they're struggling. Although access to care is a whole nother issue, isn't it? Right? You shouldn't have to be privileged to access care, and that still seems to be the case. But I think in our space, in the maternal mental health space, often women don't know what's happening to them if they don't have a pre-existing depression or anxiety, which, pre-existing depression, anxiety, even undiagnosed bipolar and undiagnosed OCD, this is really common. But to add motherhood, the layers of motherhood to it, you can be very confused about what's happening and not think that you are suffering from a mental health disorder because you're just upside down. One of my colleagues, Peck Indeman, calls it the washing machine effect, especially in the postpartum period. You just don't know what's up or down. And is this normal motherhood because I haven't slept, or is this something else? And then certainly, I think the challenges we've talked about earlier with providers not being well informed, there's awareness, great awareness activity, but provider education has not caught up or moved at the same pace. And that can be very troubling and add to stigma or question about mental health that already exists when a provider doesn't respond in an appropriate way if someone starts to have a conversation or doesn't ask, how are you doing emotionally or mentally, because this is a challenging time. If there's no question asked, even that simply, then stigma does build back up, even though we've talked about it as a society a bit more.
Dr. Gale or Allison, do you have anything to add?
You did a great job. I don't have
Yeah,
anything.
I think, definitely. It's definitely more aware nowadays with social media, with Meghan Markle and her recent postpartum depression article and talking to Oprah, and just people are more aware and they're breaking that shell. And Joy's Blue Dot Project, just so many different companies are becoming well known about mental health.
Mm-hmm.
Absolutely. I think you've teed it up. We have some really good questions I want to get to, but we might as well. You teed it up, Allison. Can you tell us a little bit about the Blue Dot Project, and also Fran, we'll go ahead and put a link to it as well.
Yeah, and it's Joy. I'm happy to talk about it, Allison. I'm so glad you know about the Blue Dot Project. I know we've talked a little bit about it, but it's Maternal Mental Health Awareness Week, as Ethan mentioned in the opening. And the BlueDotProject.org hosts the U.S. Maternal Mental Health Awareness Week campaign. Yesterday, Wednesday, was International World Maternal Mental Health Day. That launches off of Postpartum Support International. The Blue Dot was selected as the universal symbol about 7 or 8 years ago to recognize both those who suffering right now, previously suffered, those who want to support the cause. And it was launched off a separate website so that multiple organizations could get behind the movement and the project. The symbol belongs to the people, right? And the advocacy organizations. Everyone should go out and check out the social media handles of the Blue Dot Project, mostly the Blue Dot PRJ or the Blue Dot on Instagram and Twitter, Facebook, and I think that's it. We're on LinkedIn. 2020 Mom shares the messaging on LinkedIn for organizationals and professionals, but really trying to raise awareness, as Allison mentioned, on social media where moms are, right? And childbearing age women are.
Perfect. Thank you, Joy. Also, a comment at 7:34 p.m. came in from Cindy saying, "Yay, Joy Burkhard. Thank you for being such a champion for mamas."
Yay,
so,
Cindy.
Always like to give a shout out. I want to run down here quickly to this particular question. So Samantha at 7:43 p.m. asked, sorry, Joy, I think we're going to cover your face for just a brief second. What would you have done for someone who presented with contamination perinatal OCD and postpartum while breastfeeding? It was connected to the development of baby being affected by any and everything passed to the baby and was therefore severely opposed to medication because should be safe was connected to the contamination trigger when talk therapy did not help. I'll toss that to Dr. Gale.
Sorry.
No, take your time.
Yeah. So the person presented with contamination perinatal OCD and postpartum while breastfeeding. They were worried about everything, what would be passed to the baby. Okay, and then they worried about the medication and what might be impacted if it's
and it sounds
that's really hard, and I think talk therapy sometimes is misrepresented because somebody will try a therapist and say, oh, well, it didn't work for me, and sometimes it's maybe talk therapy didn't work, but sometimes it could be that it was not the right fit. We know that the relationship that one has with their therapist is invaluable, that treatment outcomes can be highly related to your relationship with your therapist. So I might ask some questions about what was their experience like, and did they try any other talk therapists. Also, exposure therapy can be really tough for people to start with. This is from a historical perspective. When OCD treatment exposure therapy first started in the 60s, you would consent to being like, if you had contamination fears, you would consent to being like tied down, for example, and then they would like throw garbage on you, and it was all consent process. But that's kind of the history, of the treatment. Interestingly, though, is that people loved that it worked, and now we've made a lot of modifications to make it more ethical. So now it's like we don't do that. People have to come in willing and wanting. But if you're so afraid of the exposures and you're not willing to do that, then maybe moving towards a mindfulness-based therapy might be helpful in managing the thoughts, and maybe seeing somebody who can help somebody manage with that. Thankfully, if breastfeeding is too difficult because of the thoughts, my immediate reaction is that the baby needs to eat. So, are they willing to try other forms of food? There's I know, and I think it's a national organization, but there's in Florida, La Leche League. Sometimes women will donate breast milk to others who are struggling and who really want to use breast milk. So there are organizations that can be that can help individuals access milk and food for their babies while they're going through the treatment. So that's a very personal decision whether somebody decides to do that or not. And I fully support whatever decision somebody chooses.
Yeah, and just to chime in there, I was super natural. Like, I did a natural birth. I was like, no epidural, nothing. I don't want any of this. And so then when I was diagnosed, I was anti-meds. I was like, no, I'm not going on any like antidepressants. Like, I'm not depressed. This is crazy. I don't need that. I can do it. I drank enough water. I exercised. I changed my diet. I was like, okay, I can do it. I can do it. I can fight it. But I couldn't in the end. And so I got a resource from IOCDF that SSRIs, specifically like Zoloft that you can hear about, typically is okay if you take it when you're breastfeeding. And so that's what I've been on since. And so if you want to go that route, because it doesn't interrupt like nursing. I'm not a doctor, but that's what I was told. And I was still nursing at the time that I was diagnosed. So I think that would be really great for you if you want to try it.
And I would agree with that statement, Allison, from my work with the OB that I worked with. She's double board certified. She's an OB and a psychiatrist. And so she would also give our clients the same information. And so that is consistent with what's in the literature. But if somebody's opposing it altogether and isn't trusting the research,
and that's just
I think,
for sure.
And I just want to be a good moderator and say that, this is by no means what you should do. You should always check with your individual clinician, whoever you work with first, to make sure that they're safe options for you. These are our personal experiences, and so we're happy to share them. But definitely, feel free to bring it to your experts, and whatever they decide is best for you, that's what we obviously encourage and support. But thank you, Allison, excuse me, and Dr. Gale. And also, Dr. Gale will also agree there, Samantha, there are also a lot of willingness to change protocols in place that you can use to maybe help move yourself toward exposures. If exposures in response prevention seems overwhelming. She mentioned mindfulness, also acceptance commitment therapy, living toward your values, reframing, why you should do exposure response prevention and things like that. There are a lot of things that you can do to sort of prepare yourself for it and get in that mind frame before you take it on. And then to also Dr. Gale's point, when you take it on, make sure you're working with somebody that is willing to start small. That's so important. You have to build that hierarchy. I always use the working out analogy. I don't go to the gym I don't go to the gym at all, but I don't get into the gym for the first time and start with 100-pound arm curls. You're going to start with 5 pounds and you're going to slowly build up. And so, if you ever walk into a situation where, you don't feel, it's always going to feel uncomfortable. And if you feel like it's too much, too fast, too soon, the last thing I'll always say, just in terms of, and this goes for anybody here, and I think Dr. Gale would agree, is when you're looking for a therapist or clinician, don't be afraid to ask questions. They're there to support you. And we know, the best practices for OCD. And there's a great article, Fran will put a post to it, on great questions to ask a therapist when you're looking for one that's specific for OCD treatment. So like, do you do exposure response prevention? But where did you practice? Where did you get certified? Where did you do degree? Does that annoy you, Dr. Gale, when people ask you those? First of all, how often do people ask you those questions? And then does it bother you when they do?
Yeah, I mean, I've had clients tell me that they researched my license to see if I had any claims against me. I think. So I think that, sorry, reframe your question because I just want to make sure.
No, I didn't mean necessarily claims. I just mean, do you mind individuals that are looking for a clinician asking questions about what you do, ERP, what your training has been, things like that?
I'm really proud of what I've done and how I've trained, and I appreciate that. And I think that is also really important in developing a trusting relationship with each other. And I think that when we're talking about exposure therapy, I mean, we're talking about doing scary things, and so you would want to feel like the person that's doing that work with you, that you can trust them and respect them. So I embrace those questions.
Allison, did you have additional? Thank you, Dr. Gale. Did you have additional thoughts to that?
No, I totally agree. Like, I've seen and talked to several therapists, and finding the right one is really important. Even if it's 5, you try different 5 people, finding the right one is really important.
Absolutely. It's hard to gauge too with OCD because if you haven't been in therapy for OCD, you have a notion about what therapy looks like. And it's important to preface, if you're looking to feel great after your session, then that's not what you should be looking for. So sometimes we're like, well, I like this therapist because I walk away and I feel fantastic. I'm relaxed. I just got a massage. We don't want that, right? So it is important to note, it is important to find the right therapist. But for OCD treatment and exposure response prevention in general, if you're feeling really good after therapy, probably want to look for a new therapist.
Not doing it let people know that at some point they're not going to like me. Like, you're going to not like me at certain points. Like, I know you like me right now, but that's going to change, at some point. So I'm just warning you now. Because I'm not friends with your OCD, you've been friends with your OCD, but I'm not friends with your OCD. So yeah, Ethan, and I really appreciate your personal stories and how, your path and Allison enjoy and, what everybody is doing, because it's hard. And I think we need to come together,
Thank you, Dr. Gale. I'm going to throw this out to everyone. Belinda at 747 asked, where can I send a new mom with OCD in need of a support group? I know the general OCD support groups, but do we have any recommendations on that specific?
Yeah, I shared on my Facebook page, but there's a PSI, is it Perinatal?
Postpartum Support International.
Support International, yes. And they have lots of resources and also state specific. And with the pandemic right now, there's a lot of digital online support groups that people can access. So that's a resource that I would give. Joy and Allison, you may know more.
I was going to agree and also say that, perinatal OCD is something we're all exploring together, including Postpartum Support International, who's on some of the work groups that we described earlier. And I know that the IOCDF is wanting to partner with PSI, Postpartum Support International, to help create OCD, maternal OCD, or perinatal OCD specific groups. So if you don't find anything yet, hang tight. There are some great groups on Facebook, I would say, including I believe there's a specific group for maternal OCD, or certainly a space where maternal OCD is discussed in a healthy and I think accurate way from what I've seen. So take a look there too. And if you run into any troubles not being able to find support, you can email me, and I'll make sure we find a support group that works for you, Joy at 2020mom.org.
Awesome. And if we haven't, we'll put her email in the links as well. Allison, were you able to connect with any support beyond therapy? Did you find anything that was helpful, even accounts to follow on Instagram or social or things like that?
Yeah. One of my favorite books is Good Moms Have Scary Thoughts. Karen Kleiman writes a really good book. And then to make like really good mom friends, I looked at different mommy and me groups, even like Gymboree and like little things like that would really help. Because you don't feel as isolated when you can go with someone and they have a baby that's your age and whatnot. You can follow me on Instagram, like as much as, you can never have enough friends. There's lots of people out there that want to support you. So
I want to follow you on Instagram. You're cool.
Thank you.
She's like, I'm not sure how I feel about that.
What's your Instagram handle?
I didn't like that face. No, I actually have a question, Allison, for you. You brought up, you kind of generated something in my head, because I know we feel this way with OCD, but when you were either pregnant or having newly given birth, how did you feel about other mothers in your groups? Did you have a lot of wonder if they were going through the same thing as you were? Did you feel like you could relate or couldn't relate? Did you do a lot of comparing?
Yes, that's all I did. You compare. I bet Dr. Gale knows exactly that feeling, as she has a little baby too. Constantly comparing, and is my baby developing the same way as so-and-so? Am I doing this correctly? I mean, within my story, I want moms to know you're doing a great job, genuinely. And it's hard. And being a new mom is a hard thing. It's a hard love. It's not, oh yeah, the baby's sleeping, I'll sleep and whatnot. It's challenging, for sure.
Thank you for sharing that, Allison. Appreciate it. I just had we have time for one last question and I'll go into. So Cindy Lee at 7:50 p.m. asked, we touched on this a little bit, how do you delineate the difference between maternal anxiety and maternal OCD? I see a lot of moms being told it's anxiety, including myself, when in hindsight, it was most likely OCD. I know previously OCD was categorized as an anxiety disorder, but it's now its own category. Has that changed how we address anxiety versus OCD? Joy is feverishly nodding. It's not really feverishly, but Joy, go ahead.
No, I mean, it's a great question. And actually, Cindy is on our team. So I just am grateful for her question. And I think we should kick that over to you, Dr. Gale, to talk about the nuances between generalized anxiety and OCD.
Yeah, I think the quality of the symptoms are different when it's OCD versus anxiety. One is anxiety is drastically underdiagnosed. And I think that what we find is that when we treat OCD, that the depression usually falls off, that the OCD is primary. So this is also why it's so important to diagnose it appropriately. And I would say the same is true for anxiety and depression. If you're treating the anxiety and the depression, now the depression is going to fall off, or subside, hopefully. But with generalized anxiety, it's worries that are a very common shared experience. I'm worried about my job, maternity leave and what's going to happen in that transition. But it's at this heightened level. There might be loss of sleep, there might be irritability, but the quality of the fear is, related to job, family, things at school, stress that a lot of people experience. It's just exacerbated and affecting somebody's quality of life, and it's impairing. Whereas with OCD, it might be, I'm afraid that, something bad's going to happen to my baby. Something bad's going to happen to me. I'm not going to be able to care for my baby. There's a large focus around, and it's irrational. It might be absurd, weird. That's weird that I thought about raping my child. I never thought of myself as a molester, but maybe I am. Maybe I'm a predator. Maybe I shouldn't be around my baby. Maybe we need cameras in every single room, and my partner and my family members to watch to make sure nothing bad happens. Things like that. That's, so I think we got to look at the quality and the domains. And if there are domains that are hitting that are related to OCD, then let's classify as such so that way they get the proper treatment, because the treatment for anxiety and the treatment for OCD are different. And I think we haven't really done a great job educating people about the differences in the treatment. It's like, if you went to your doctor and you had an illness and they said, oh, well, you can try vitamin C, an antibiotic, or, a lifesaver. Which one do you want? It's like, I don't know if I want to go to that doctor.
I like that.
And I think that's kind of what we've done in our field. We're not really letting people know. And we also have this issue where sometimes therapists, and I don't think it's malicious in any way, but are saying they treat OCD when they don't. Mm-hmm. And there's research on this. I think it was like 80% of clinicians that posted that they treated OCD at that time didn't use the correct treatment modality when they were given a checklist. That's a problem. So we also need to educate people on where to go to find the person specialized with OCD. And IOCDF has a really nice provider database. They've also expanded it to include therapists of color if you're looking for somebody, a therapist of color. So that's a really great resource. Also, IOCDF does a nice job in making sure that not just anybody throws our name on their provider database. Mm-hmm. Some agencies do that, and you don't always know what you're getting. So,
yeah, don't get me started on that. I went to 10 therapists before I found proper treatment in 17 years. And I think it's a problem at the education level. Half a day of abnormal psychology does not, make you an expert in OCD. We're running out of time, unfortunately. So I want to give, and thank you so much, Dr. Gale, for your expertise and on all of these great subjects. I want to actually give Joy and Allison final thoughts. What would you like people to know? I'll start with Joy.
Yeah, just to add on to that last point is that if you're looking for support in this space, what I would do is look at the IOCDF directory and the Postpartum Support International directory and see where the overlap is. That's where you're going to find the experts in this space, I would say, and hopefully people know about both. And then PSI, Postpartum Support International, uses the tagline, you're not alone, you're not to blame, and with help you will get better. And that's what we want people to know here in this space too. Keep talking about it and come online and find your community, find your people. And if your provider listening, let your patients know that there is help and they will get well, and to find community online as well.
Thank you, Joy. And Allison, even though I just discovered you blocked me on Instagram already, I would love to know. I would
not true.
Anything. No, totally kidding. Anything that you would, any last thoughts that you feel is really important for mothers to be or mothers to know?
Everyone's doing a great job. Ask for that support, ask for that help, and know you're not alone, and there's so many great resources out there. And thank you guys for being here and being on this. And this is awesome work.
Great.
Thank you, Allison. Thank you, Joy. Well, I definitely want to thank Dr. Cindy Gale, Joy, and Allison for joining us. As always, thank you all for your questions and comments. There's some amazing links and threads throughout the comments. So threads on Facebook and YouTube and Twitch. So please feel free to go back. I always like to suggest going back through the comment threads and check out all the various links that Fran posted, because there's some amazing resources in there. Don't leave quite yet. Just have some quick housekeeping stuff to do. So first and foremost, I want to mention a study that's going on. Fran will put a link to this. Volunteers are needed for a research study on thoughts new mothers have about infant safety. Are you a mother with an infant less than 6 months old? Are you pregnant and expecting soon? you might be eligible to participate in a research study on thoughts postpartum women have regarding infant safety. We are particularly interested in thoughts that may be repetitive or intrusive. It's a dear friend of the organization conducting this study. The IOCDF has just posted a tiny URL link. You can find out more information there. So thank you, Dr. Lisa Coyne at Harvard for making us aware of this study. If you feel you can participate or you qualify in those ways, please feel free, or if you don't, feel free to check out the link. So for upcoming virtual events and live streams, you can check out iocdf.org/peace of mind. That has all of our virtual events every week. Some upcoming events for next week, Wednesday 5/12 at 7 p.m. Eastern, we have our very first Anxiety and Athletes lead advocate, Tom Smalley, will kick off his live stream series on how OCD and anxiety affect the athletic community. Incidentally, I will never be a guest on there, but it's sad, but it's true. But that's why he's hosting, not me. Also on Thursday, not Tuesday, but Thursday at 7 p.m., there will be an episode of Just Ethan, just me, talking about all things OCD. Sorry for the calendar change, but it will be on Thursday for next week. A few other quick calls to action. On May 21st from 1 to 5 p.m., we are having our Faith and Mental Health Conference. Registration for our first ever Faith and Mental Health Conference is open. It'll bring together a diverse group of faith leaders, therapists, those with lived experience for a one-day event on Friday. Have I mentioned that it's free? It's free. So if you have any interest in this, if faith, if you're elite, whatever, check out, register online. Did I mention it's free? It doesn't cost. There's no excuse to check it out. It's going to be an amazing conference with some phenomenal panels and individuals and conversations. I think 600 or 700 individuals are already signed up. So please check it out. Also, I'll make this quick. There's an anxiety and athlete survey and an anxiety and faith-based community survey that we are looking at needs assessment. Fran will put links to both of those. Everybody asks me what are ways we can advocate. This is such an easy way to advocate. There's the anxiety and faith-based community survey. In fact, let me just help Fran here out a quick sec, and I will post these in our private chat so he can put them as links. And that is our athletes and anxiety survey. There you go, Fran. So you can check those out in the links below. So yeah, that covers just about everything. Again, I want to thank our guests, Cindy, Joy, and Allison for joining us. As always, I want to thank the IOCDF and, of course, my partner behind the scene, Fran, for his digital voodoo. If you haven't already and you want to be notified about all the programming the IOCDF is having over the next month, definitely be sure to subscribe and follow on YouTube and Facebook. And we are also live on Twitch. Hey, now, we need to remove the new, though, Fran. We've been there a year now. We need a new graphic. Sorry to call you out, but it's true. Anyway, so as always, thank you so much. Oh, email addresses. If you have any questions for the IOCDF whatsoever, you can email us at info@iocdf.org. Also, oh, there's a cute kiddo right there. We see a head. Also, no, it's totally okay. Also, if you have any questions for Dr. Gale, for Joy, or Allison, and you didn't get their email or you want to reach out, please don't hesitate to email us at info@iocdf.org. Just let us know that you have a question for Dr. Gale, Joy, or Allison, and we will be more than happy to forward your question on to them and get you an answer. It's cute. It's really cute. Anyway, so with all of that, thank you for spending your Thursday evening with us. Have a wonderful evening. Stay safe, stay vigilant, feel the feels. Don't let OCD off the hook. We will see you next week. Have a beautiful night. Thank you again to our guests. Talk to you later.
Thank you.